Okay, really fast. Can people online just indicate that they can hear me? Okay. I think, awesome. I see thumbs up. Perfect. Okay, so. Okay, good afternoon, everyone. Welcome to SOAR's first Psych Talk of the spring 2023 semester. So many of you know me, but my name is Miranda Connelly, and I am the current president of Scholars of Academic Research. Thank you all for coming this evening or afternoon. So some quick housekeeping before we begin. I would like to ask everyone to please silence their cell phones if possible, and to please refrain from taking videos and photos. There will be a dedicated section at the end of the talk to ask questions, and everyone on Zoom can put their questions in the chat. This talk will be recorded, so please just sit back and enjoy some pizza and learn about the science of aging. Okay, so today we have the pleasure of hearing from one of Humboldt's own esteemed psychology associate professors and board certified behavior analysts. Yes, esteemed. So Dr. Christopher Walmsley. Dr. Walmsley received his undergraduate degree in psychology at the University of New Hampshire in 2007, where his passion for behavior analysis began. Walmsley then went to Western Michigan University in 2009, and which is where he obtained both his MA and Ph.D. in behavior analysis program under Dr. Wayne Fuquay. That's correct. Where he also became a board certified behavior analyst. So now, as of now, Dr. Walmsley's research is centered in behavioral gerontology, the intersection of the science of behavior and the unique issues an individual faces as they age. Dr. Walmsley's current research interests include the refinement of behavioral technologies to assess for and promote adaptive functioning in older adults with neurocognitive loss, and in particular, how to best treat the behavioral and psychological symptoms of dementia. Dr. Walmsley is a published first author in academic research journals, has presented his research at national conferences and poster sessions, and tonight we have the pleasure of listening to his talk on his current work in behavioral gerontology. Without further ado, please welcome Dr. Christopher Walmsley.
Thank you, Miranda. Thank you to SOARS for inviting me to give this talk. Any chance I have to talk about aging, I will take it. But please don't use that fact to exploit me. Before I go into my talk, first a joke. Now, the term, maybe some of you are familiar with, trimmigrant. Folks that come all over the world to trim marijuana in those farms. Well, trimmigrant has a bit of a negative connotation, right? So I think we can rebrand trimmigrants. Instead of trimmigrants, we should call them grow-getters. I'll work on that. I'll practice open mic. That's not an accident. Well, again, thank you all for attending here in person and on Zoom. Good to see everybody. The title of my talk is Gerontology, Research and Practice to Help Surf the Silver Wave. And this image here I came up with, I had AI create through a text-based image generator, it's called Cryon. I tried to plug in different terms to have a nice little artistic expression, visualization of the silver wave. One such attempt actually had me enter in terms about an actual older adult surfing. And I don't know if some of you know, you can't really see the image here, but AI still does a terrible job of faces. Some of you may have noticed it looks like a melting claymation face. It's a bit unsettling. Anyway, I got a good laugh out of that. Okay. So my agenda. Yes, I do have an agenda. First, we'll start out with some basic definitions of gerontology and the science of aging. Then let's move into changing demographics. What do we mean by the silver wave? Also referred to as the silver tsunami. Then we'll go into one sub-area in gerontology, behavioral gerontology, which is actually a subspecialty in behavior analysis. I'll provide an example of research that I and colleagues have done in the area of behavioral gerontology. And then I'll leave you with some resources. If you want to learn more about psychology of aging, gerontology more broadly, both at the university and also in the greater community in Humboldt County. I strongly suspect that a good proportion of you folks have an aging loved one who maybe even is suspected of beginning to develop some form of neurocognitive disorder like Alzheimer's. And so again, there'll be some resources that for volunteering, for learning more about aging in academic settings, but also aging resources you can share with your loved ones you might not have been aware of. Let's start with a fundamental question, folks. What are we talking about when we talk about older adults? And how do we refer to them? Elders, older adults, seniors, the elderly, the infirmed? Probably not that last. Well, the short answer for how do we address them is, well, we ask them how they prefer to be addressed. No secret there. But what about what do we consider to be an older adult? At what point do we say, you're no longer an adult, you're an older adult? What happens there? Does it happen overnight? Like some kind of weird aging Cinderella story? What's going on? And so if I were to ask you to close your eyes, imagine an older adult. You might imagine maybe somebody with gray hair or the loss of hair, the lack of hair, pronounced skin wrinkles, aging spots, perhaps maybe you picture not necessarily the features, what an older adult looks like, but some stereotypes, negative stereotypes about aging, like, well, all older adults are, lonely, isolated, and they're really losing a lot of their self-worth. And so maybe that image at the top right is something that comes to mind. But I want to start out by saying that just the appearance of aging doesn't tell the whole story, and we can't necessarily, and there has been research to try to correlate physical changes with aging with chronological age. And chronological age is a terrible predictor of a range of outcomes, health status, how rapid or slow one's aging appearance is, and so on. One 72-year-old does not look the same as another 72-year-old. These are the physical features of aging. I'm sure you all know, especially if you go to like Lost Coast Outpost and you look at the mug shots of folks, right? It's like, oh, this looks like a 65-year-old person. But no, they've just been doing meth for 30 years and it's taken quite a toll on their body, right? So they significantly look like they're they are. So behaviors and the environment also has a very powerful influence on the aging process. It is not purely biological. But again, I want to come back to this point. Sorry, forget that I have a mic. I want to come back to this point. So audience participation time. This includes in Zoom. What would be the age you consider a person to be an older adult?
65.
65. Okay. Anybody have an alternative? 80. Wow, which is greater than the average life expectancy, 77. So that's a tough criteria. Okay. 50. Okay. So he says 55. Well, consider this, folks. That actually is the audience that determines who's an older adult. Now, if you are applying for Social Security retirement, you're born before 1960, the federal government considers you to be an older adult when you are 65. However, if you're born after 1960, the age at which you get full retirement benefits or Social Security is 67. Is everything okay there, Miranda?
Oh, yes, it's just our bad.
Oh, okay. 67. In the United Nations, right, over in Europe and internationally, they generally tend to consider 60 to be the age at which somebody is considered to be an older adult. If you go into your local grocery stores, convenience stores, at what age do you typically have to be to get a senior discount? 55, that's right. So in the eyes of those organizations, you're an older adult if you're 55. And maybe some of you know this. If you are a woman pregnant, 35 or older, what do they refer to your pregnancy as?
Geriatric.
Geriatric pregnancy. Yes, many women become not all that happy to hear that they have a quote unquote geriatric pregnancy. Yes. So the medical community actually determines, again, if you have a geriatric pregnancy, they want to make sure that they're doing additional check-ins and all that because there's an increased risk of potential complications. I mean, there will be, but there's an increased risk. And lastly, folks, maybe you know somebody who worked with an individual with Down syndrome. People with Down syndrome experience rapid accelerated aging, so that if they hit age 40, they look like they are 60 or 65. So they rapidly age compared to folks who don't have Down syndrome. And that means that they're at especially increased risk of developing early onset Alzheimer's, in their late 30s. So again, context is everything. And the audience ultimately determines, well, who is an older adult given a given context. Okay, so I think I've belabored that point enough. Who's an older adult? Let's move into another basic concept, or distinguishing between two subdisciplines. First is geriatrics. This refers to internal medicine. The professionals involved here are medical professionals, psychiatrists, nurses, medical doctors, so on. And the goal here is to apply the medical model. Right? So if an older adult has some kind of illness, they provide medical treatment in the hopes of, if not curing, at least managing effectively that illness so they can continue to have some kind of quality of life. So that's medicine, geriatrics. Gerontology, on the other hand, is the multidisciplinary study of old age. So this area focuses on the impact of biology, psychology, and sociology, and how that produces changes with aged individuals. It should sound somewhat familiar to you folks because this is applying a biopsychosocial model in the context of a lifespan perspective. So gerontology takes a lifespan perspective. The counselors, psychologists, sociologists, historians, creative writers, anthropologists, and yes, even behavior analysts like yours truly are involved in gerontology. So it is a very rich, multidisciplinary field, and I have formed some very, very reinforcing professional collaborations with folks and learned a lot from other professionals working with older adults. Now for some statistics, for some facts. This graph shows you the birth rates per thousand across the years, the x-axis. Notice, also, people on Zoom can see my cursor all the way down.
Yeah, I think they can.
They can, okay, wonderful. So notice here, after there's an overall decrease in birth rates, starting around 1946, there was a spike that occurred through 1964. Does anybody know what cohort this is? World War II cohort, also referred to as the baby boomers. Yes. So if you were born between 1946 and 64, you were part of the baby boom cohort. Now notice after the baby boom cohort, birth rates have declined and stabilized. That is continued throughout this day. What are the implications here? Well, imagine this being, going back to the title of my talk, a silver wave. As this cohort ages throughout the decades, we're going to experience greater stress on our infrastructure, our healthcare systems, other levels of care, in trying to accommodate the ever-increasing needs and unique needs older adults face in our communities. So again, you can imagine as this cohort ages, it is a wave of older adults. And starting in 2011, the first baby boomers started turning 65. In 2023. So that means baby boomers are reaching even further advanced ages. Among older adults, there are three subgroups. Ages 65 to 74. Those are considered to be the young old. 75 to 84 considered to be the middle old, and 75 and above the old. That sounds like 1984 double speed.
It was 75 to what is old?
Yes, 75 and above is considered old.
Okay.
Yes. Yeah, I haven't directly talked to any older adults, but I wonder how they feel about that. I mentioned these subgroups because the fastest growing subgroup, the old, is at the highest risk of developing health complications, including some form of neurocognitive disorder like Alzheimer's. In fact, 1 in 3 people over the age of 85 will go on to develop some form of neurocognitive disorder. So you can imagine, as we're experiencing greater proportions of older adults in the US, and this is also mirrored in other developed nations like parts of Europe, Japan, New Zealand, Australia. We're going to see greater increases of neurocognitive disorders. That means increased needs for those specialized care services. So we need to prepare ourselves, folks. That's a good awareness. Here's some other data. These look at, so again, the obtained data from 2016, 2020. Go, and then we project out the anticipated numbers and percentages of older adults that make up the US population. You can see here, 2016, number of older adults, 65 years and older, 49.2 million, makes it 15% of our total population. By 2060, almost 1 in 4 Americans will be an older adult. Oh, well, that's great, cool. Right, we're also still having plenty of babies, right? So there'll be plenty of young people, right, to help and provide care and supports for them. No, folks. Birth rates have been declining in the US and other developed nations for quite some time. So this is another problem. We're going to have more older adults and fewer younger adults, or traditional working age folks, that will be able to provide those supports to older individuals. By 2034, this is the anticipated tipping point. It's estimated that the proportion of older adults in the US will eclipse that of younger folks. So it'll actually start to be an equal proportion of both younger and older adults in 2034. After that, more older adults than younger folks. So again, that has implications for our workforce. Our workforce will continue to age. How will businesses and organizations provide universal design sorts of accommodations so that the folks in that aging workforce subgroup can continue to work and be productive and stay within their valuable job. So I've gone over the basic concepts and why it's arguably important to study aging and to plan for it. And sure, we should continue to pump in research funds for cures for Alzheimer's and other neurocognitive disorders. Absolutely. But we also can't just sit on our hands and wait for a cure. We can also do research and improve our practices around the care of older adults. Care of older adults can always be improved, and ideally through evidence-based practice. There are a number of areas of clinical application. I could spend more time and have more little bubbles here, like around end-of-life care issues. It's a whole separate issue, like palliative care, hospice. Talked to a couple of my students, they're like, yeah, I provide end-of-life care supports for older adults. I'm like, it is a bummer. In fact, for my own mental health, I'm gonna have to bow out of that job. I get it. I hear you folks. It is a heavy task, constantly surrounded, reminded of death. It's not for everybody, but it is a very important element of care for older adults, so that we can maintain as best we can their rights, their dignity, their quality of life, even in the last few months or even days of their life. So health status, probably one of the most significant variables that most affects levels of independence and autonomy among older adults. Researchers and gerontologists in the 60s and 70s came up with this term and wrote a book on it called successful aging. And they defined successful aging as moving throughout the life course and also successfully avoiding or preventing health complications, mental health challenges, and so on. But then as there are more discussions in those academic areas, it turns out that actually that's a bit of an ableist definition of successful aging. You assume that, well, you're successful in your aging if you're able to avoid arthritis, cancers, hypertension, etc. A refined definition now is, I think, a bit more workable, a bit more problem solving and focused. That is, well, in spite of changes in or declines in functioning, whether it's sensory functioning, physical functioning, etc., how, even in spite of chronic health conditions, can one still successfully navigate them to maintain their quality of life? So that is generally agreed to as the working definition of successful aging. Maintaining quality of life as one reaches advanced ages. And viewing aging as just kind of another problem to be solved, right? So being able to flexibly problem solve and engage in compensatory behaviors and other accommodating strategies that you might not otherwise think of, right? So when your vision starts going, like mine, when I was in 5th grade and my math teacher noticed, because I'm a W, so I'm in the back of the room, you know, when she sees me squinting at the room, well, the intervention is get him some glasses. And so again, there are a lot of prosthetic sorts of environments we can provide the older adults at the intervention: glasses, hearing aids, so that they make sure that if there's sensory decline, we can make accommodations there. So health management, very important. We can help them successfully manage any kind of health conditions they have. That's very important. And we can teach them skills like self-monitoring. Yes, self-monitoring is a term some of you in my classes hear probably way too much. So sorry, not sorry, but we can teach the older adult, right? If they and work with them, collaborate with them on their goals. Okay, I want to exercise more. I want to go on more frequent walks. I increase my step count. Well, you can teach them to self-monitor and effectively set smart goals. Those are specific, realistic, attainable, yes, measurable, right? Time sensitive. You know the acronym. So that they can engage in that behavior and hopefully change their own behavior. So that they are engaging more health-related sorts of activities that will stave off or slow down physical decline, let's say. And that's relevant to falls, because if an older adult has a fall, that is the *1 predictor of them becoming institutionalized in some way. Skilled nursing facility, let's say, because that means that they will likely suffer another fall in the future as well. So there are really nice prevention strategies to increase balance, stability, things like Tai Chi group classes have a really good evidence base for decreasing the risk of falls. So again, we can collaborate with folks who offer those sorts of strength training exercise programs. We'll link up older adults. Again, if that is one of their goals. Because the bottom line is for many older adults, they really want to age in place. In the home that they've raised their kids in, they've cared for their grandkids, they've lived decades and decades there. That's a big deal for them. It's often a common clinical goal. But even then, right, if they do need a lot more supports that can be afforded by a family, maybe the family's been providing care, but there's further decline, and so they're getting really burnt out. Working with them for a care plan, a transition plan, right, to transition them to, say, skilled nursing or assisted living. And there are good and not so good ways to do that. The worst way to do that is to surprise them. And usually that's what's happening. We'll do this in secret. No, they're not going to be happy with it. So we're just going to surprise them and say, oh, we're going to Disneyland. And it turns out you're going to an assisted living facility to drop them off. That is the absolute worst way to transition them. Yeah, education. Right? A lot of care providers, or specifically family, that are caring for older adults. Many of the caregivers are also older adults, a spouse or an aging loved one. And how can we provide education on what to look for if they suspect cognitive decline due to Alzheimer's? So a lot of education around aging processes, what to look for, because this makes us uncomfortable, let's do the wait and see approach is not a good approach. That oftentimes will result in elder neglect because they won't be educated on the warning signs. So, oh, well, yeah, I noticed, her mail's stacking up. I noticed, yeah, she's not tossing out her spoiled milk. Her hygiene has been kind of an issue. She's not showering anymore. But I don't know, we just assume that's just normal aging. That is not normal. So it's important to provide education resources, caregiver trainings, to be able to effectively respond to that. So it doesn't lead to neglect. Back to falls. I don't know if this, maybe somebody in the audience can correct me, but Dr. Justice Ortega, kinesiology used to, maybe still runs, a fall prevention program in the kinesiology department. I think it's called the Balance and Fall Prevention Program for Seniors. So they go out and recruit folks who live all around Humboldt County, yes, even deep in the hills. This program. All right, in the interest of trying to move here, but these practice areas, I guess the bottom line is that they can inform research by highlighting certain questions that can be asked in a research context to help address gaps in knowledge around the care and ways to maintain the quality of life of an older adult. And then the research findings inform that practice. So there's this nice bi-directional feedback loop between research and practice, gerontology. So drilling down into one subfield in gerontology, also a subfield in applied behavior analysis, behavioral gerontology. Really, it's the application of behavior science, behavior analysis, to the unique challenges older adults face that Miranda beautifully summarized in their introduction. You go in, if you're a behavior analyst working with a family, and some of you are maybe familiar with the common ABA model around early intervention work, school-age kids with learning disabilities. It's a board-certified behavior analyst trains behavior technicians to implement the interventions in the home, the school, the community, wherever it might be, the need might be. Well, instead of behavior technician, well, we train whoever's providing direct care supports to the older adults. It could be a home health aide, certified nursing assistant, a family member. So we go in, we do a behavioral assessment It's couched in behavioral principles. Yeah, look at the ABCs of behavior, just like we do with other clients in other age groups, behavior analysis. We look at what are the antecedents. So prior to behavior occurring, challenging behavior. Again, repetitive questions, wandering, aggression. These are not always uncommon when a person has, especially like a neurocognitive disorder. So identifying the triggers, so to speak, what sets off the behavior. And then getting working definitions of what those behaviors are, what they look like. Lastly, what follows behavior? What happens after behavior? How do caregivers respond? What changes in the environment? What might be reinforcing or punishing? Appropriate or not so appropriate behavior. Consider a case where a caregiver is seeing an older adult struggle to get their shirt on. So it's somewhat aversive for you to see somebody struggling, putting clothes on, engaging in activities of daily living. So what do? You do the task for them. Oh, let me get that shirt. Well, you just missed out on a learning opportunity, or that's more for early intervention. It would be more like a maintenance opportunity, right? They can still physically engage in the behavior, just might take them a little bit longer. Well, it's pretty important to train caregivers to provide a minimal amount of assistance, not doing it for them, but how we can issue an effective set of prompts to get the behavior to occur. That's important. So they constantly are doing things for them. Well, this might create an environment in which dependency behaviors are reinforced. And people say, well, yeah, they're just not doing anything because that's the dementia. No, it's not. Again, that takes a hard medical model approach to dementia. The environment has a lot of influence on behavior, even when a person has the debilitating condition like Alzheimer's. Consider another case. Older adults is beginning to experience word finding difficulty, which might indicate changes in cognitive functioning, might indicate the beginnings of some form of neurocognitive disorder. And so the family members, all right, they try to be patient as the person's trying to find their words, but then they get impatient. So they start finishing their sentences for them. Well, they might be, functionally speaking, punishing appropriate attempts to communicate, which further suppresses verbal behavior, which then looks like, oh, well, that's just the dementia. So those are environmental influences that are compounded on neurological changes occurring. So it's very important to do these kind of behavioral assessments to figure out what's going on in the environment that's influencing behavior. I'm going to illustrate kind of a behavioral analytic approach when it comes to two behavioral challenges associated with neurocognitive disorder. Wandering and quote unquote aggression or non-compliance around care routines, especially bathing. Now, folks, another big predictor of a person being institutionalized is the presence of challenging behaviors. Excessive wandering, aggression, whether it's verbal or physical, can be hard for caregivers to manage, and it results in a lot of burnout. So it's important to go in, effectively treat them, manage them, so that the older adult hopefully can continue to age in place with their current care supports. So let's start with wandering. Whenever I've gone in and consulted, I never include in the definition of wandering aimless, because wandering is never aimless if you understand the function of that behavior. So that requires effective an assessment to be done. First question you ask is, well, what's their reinforcement history for milling about? Take a case where maybe one other adult was postal worker, constantly driving and walking around their different routes, certain times of the day. Maybe an older adult, that's how they like to start their day. Coffee in the morning, and then they go for a walk or a jog. However, it's interesting, right, that throughout our lives, until we become an older adult, we're constantly walking around, navigating our environments, the exception of the beginning of the pandemic. our own Dr. Tasha Howe told us at a faculty meeting, I took 50 steps the entire day. Fitbit was tracking your steps, but all right. Regardless of that, generally, there's a lot of reinforcers for working around university, work, because we have to, right? Complete tasks, or just to walk around the beautiful forest, beautiful Humboldt County. Get those natural reinforcers. Well, for some reason, in large part, I'm sure, to our ageist culture, when an elder adult starts walking around, that is a problem. We just want them to sit down, engage in passive activities like, oh, just read or knit or watch TV or something, right? Or just hang out with the little Shih Tzu, you know, just hang at the Shih Tzu, just hang out. So a lot of folks consider, oh, it's a problem when they're wandering or walking around. But again, perhaps they just had a morning walk at 7 a.m. every day. And now they're in an institutionalized setting, right? So they're just, that behavior is at strength. It's very likely to occur. And then they attempt to be redirected by staff, and then that results in aggression and other problems. We also have to consider, well, what were the reinforcers? What was their learning history around being ambulatory, walking around their environment? And again, even in the assisted living facility or other skilled nursing facility, you can see if somebody's wandering, what happens, right? Staff will try to redirect them. Ooh, we've got coffee and cookies, or we've got activities here. So they are presenting potential reinforcers for wandering, rather than engaging in other behaviors. Again, you have to consider the care environment, how they might be inadvertently reinforcing behavior. Also consider, aside from reinforcement history, you need to do some medical rule-outs too. Folks, I don't know if you have ever experienced a chronic pain condition where you cannot get comfortable sitting or laying down. Any locomotion produces, however minimal, some relief from those symptoms. And there's been research to show that a high number of folks wandering around, say, a skilled nursing facility, have undiagnosed infections like urinary tract infection or other kind of pain condition. And the walking around is a way to help manage that pain. But of course, they can't necessarily verbalize that. The neurocognitive disorder has really robbed them of their speech. They're no longer talking. So I always wonder that whenever I see a group of older adults in a skilled nursing facility wandering around, reportedly aimlessly, how many is just like the recommended course of action is, when's the last time they've seen a doctor? Maybe get them in, get them checked out, see how they're doing health-wise. Because then when you actually treat an undiagnosed pain condition, the wandering goes away. When it comes to bathing or care routines, again, I never call it aggression or non-compliance with routines. Imagine you're an older adult suffering from memory issues, and you're at a skilled nursing facility, and some staff member still wearing a mask because they're required by the state, facial covering. So they're a stranger to you, and they come into the room and just matter-of-factly say, "All right, I want you to get undressed because I'm going to get." And then when they start protesting, then the nursing staff begins issuing some physical prompts, which then evokes aggression. It's not aggression, it's self-protective behavior, folks. Right? Imagine you're in that situation, you don't know where you are, you don't know who these folks are, and they're asking you to engage in a very intimate activity of daily living in their presence. I think I would start trying to protect myself. Again, we asked, right? What were their preferences around bathing routines? Maybe it's, it's somebody they're comfortable with. You're asking them if they're ready in the right ways, but they're still resistant to the bathing routine. It can be as simple as, what are their preferences? Do they like, lights, incense, or candles, listening to music, preferred shampoo, or other bathing materials? What about the time of day? Right? Maybe it's like, well, at the facility, everybody's got to shower at night. Why? I know I prefer showering in the morning. I like starting my day. It helps me wake up. So imagine if I'm an older adult, so they try to force me to shower at night, I'm going to probably get aggressive too. So there's somewhat selfish reason for me to get in this field, because I hope that care will improve. So when if I'm lucky enough at advanced age, people can help me out. What if in the bathroom, you got those cold linoleum tiles? You don't have the heat on, right? It's like, oh, it's so cold on your feet. Well, it turns out I was consulting on a case, and this was exactly the case. This poor woman, again, she didn't have good intact verbal behavior because of the neurocognitive loss. She couldn't verbalize it, like, oh, I don't like it when my feet are cold. So she would refuse to go into the bathroom to get a shower. Can you guess what the intervention was? No, not sedatives, not a pharmacological intervention.
Bath mat.
Bath mats, yes, throat rub, something, right? So that they aren't contacting that cold aversive fluid. That was enough to stop the quote unquote non-compliance, that care routine. Once you understand the function, you look at the ABCs of behavior, you start to make sense of what's going on. And another example, it's consulting a case where the husband was providing that bathing care to the wife. And it turns out he was unknowingly grimacing during it because he's struggling, he's stressed, he's probably experiencing caregiver burnout, right? This is his wife. He's been married for maybe 50 plus years. Now he's having to bathe her. That was stressing him out too, but he wasn't aware of these kind of like grimacing faces he was making. And the poor wife, you can imagine, seeing that, would respond with some pretty intense emotional behavior. So what we did was, thankfully there was a mirror in the back. We just trained him to look at the mirror and check in on himself every once in a while. He wasn't grimacing, so we were removing that antecedent, and then the bathing routine was a lot more smooth after that. Talk a little bit about one study I've done here, and other colleagues, Aaron Watkins and Al Poling. And this is a study looking at self-reported happiness of older adults in assisted living facility, and differences in happiness levels depending on whether they were in activity or not in activity. Because in a lot of these facilities, it's very important to keep them engaged in activities. They're not just isolated, lonely, and we want to get them in meaningful activities. So assessing happiness level in people with language impairments can be a challenge, as you can imagine. But in healthcare settings, there is something like this they might present to folks. Point, they call it a point scale. So say a scale from 1 to 6. 1, you're absolutely unhappy. 6, you are ecstatic. You just want to love it. And this has been shown to be a somewhat reliable and valid way to assess pain levels in medical patients who can't otherwise verbalize their pain levels. Previous research has also looked at measuring behaviors related to happiness, like smiling, laughing, maybe types of body posture indicative of happiness. And so we were interested to see, okay, there's good research to show how to get older adults engage in activities, but how does it impact the quality of life? Arguably, happiness, pretty important construct related to that. And yes, folks, that's right. Even in behavior analysis, we deeply care about a person's happiness and their thoughts, feelings, and emotions. So here's what we did. We recruited participants from an assisted living facility. Directionality of my mouth. Sorry, folks on Zoom, if my audio is somewhat poor. That's my fault. We recruited 6 older adults. Age range was 86 to, that's right, You read that right, 106. Anybody know what we call folks who reach the age of 100? Centenarians, yes, which sounds really cool. It sounds like a Roman imperial guard member or something. Anyway. So 4 females, 2 males, and our dependent measures include both a participant report, so the older adult reporting on their happiness level using the scale, and an observer report of their happiness level. So happiness was scored in terms of facial expressions, body posture, and other overt behaviors. And being in an activity is defined as being within 5 feet of one or more residents who are involved in some kind of social or interaction. Playing cards, planting flowers, some other structured social activity. Or it could be a non-social activity. So the older adults alone, but they're engaging with materials like reading, painting, drawing. Observations occurred 1 to 3 times a day between 9 and 6:30 p.m. Across a sufficient number of days to do 10 observations of happiness levels for each participant in activities, 10 observations of their happiness levels when they were not in activities. If the participant was in, say, their private room, or family was visiting, they were, say, in the middle of like a physical therapy session, we did not do the observation. We did not invade their privacy. So this actually took quite a bit of time for some of these folks. We had to go, do 80 observations to get 10 observations in an activity and 10 not an activity for some of these folks. What we were able to do. So we used a time sampling procedure to collect that data. So that involved the researcher entering the facility, and then when they came across each of the 6 participants, in that moment, they observed them for 3 seconds. And based on that observation, they indicated, all right, what their happiness level was based on that 1 to 6 face scale. They then approached the older adult with that face scale, presented it to them and said, hello, I'm here to ask you a question. Can you point to the one that best represents you right now? You allow some time for them to respond. If they didn't respond, you represent the instruction. If they still didn't respond, then you just said thanks and buggered off. It wouldn't bother them anymore. That only happened on 2% of the observations though.
Thank you.
So that was our procedure. Well, not I. Another person on the research team did a chi-square test. So yes, we do statistics sometimes. And we found statistically significant results here. So this is a graph of the participant reported indices of happiness. The y-axis, we get the frequency of ratings. And then those ratings 1 to 6, 1 being very unhappy, 6 being ecstatically happy, maybe even manically happy. So what were the takeaways here? Well, you can see the data were negatively skewed. So in general, ratings below 4 were infrequent, regardless of whether participants were or were not engaged in activities. And the bars, the dark bars, black bars, that refers to observations in an activity. The gray bars, those are the observations when they were not in activity. You can see, though, overall, somewhat clear pattern. Ratings of 4 or above occurred 83% of the time during activities, whereas ratings below 4 only occurred 22% of the time they were in activities. So they're more likely to rate or indicate that they're happy when they're at activities versus when they're not. And here are the observer reported indices of happiness. Again, you can see here, yeah, there's some negative skew, but also they tend to cluster up the results as either a 3 or a 4. So they overall tend to rate the older adult as generally being happy. But still, the results somewhat mapped on pretty well to the participant ratings. So these present findings mapped on with earlier investigations of indices of happiness in various contexts. So this might be a good way to improve their happiness and their quality of lives if we structure and carefully plan out a variety of activities in these care settings. And it could be a quick assessment to gauge the quality of care being provided. The older adults at a resident or a facility are all, indicating they're unhappy. Administration should probably take it. Okay, a few minutes or maybe a minute I have. Some community collaborations. So I've had the privilege and love to collaborate with folks, Area 1 Agency on Aging. So this is their home base is in Eureka, but it's really a hub of services for older adults. I believe it's 55. Qualify for a lot of these services, you're 55 or older. They provide a lot of supports around navigating Medicaid or Medicare, finding housing, applying for Social Security, helping them adjust to retirement, so on. So I have a grad student and I, we're going in and just doing a needs assessment, and we found out that there's a nutrition program that during the pandemic, well, they just turned into basically like a grab and go. They had meals that the older adults would come outside and grab and then leave with that food. But they wanted to reestablish essentially like a community style dining program. So they had a cafe, and well, not too many folks were coming in since the start of the pandemic. So they were interested, and we thought we could help with that with a research question. What are ways we can physically arrange that cafe, the environment, to make folks more comfortable and happy and engaged? So one of my students is actually just about to start collecting data. She's across 6 weeks, systematically manipulating the physical layout of the room. So either like have people a bit more like isolated with curtains and all that, if they kind of want to be alone, versus a more social environment. There's large circle tables, people can gather around. You want to compare levels of happiness and a measure of engagement under those sorts of environmental arrangements. So we're excited to get that data, and hopefully that will inform the practices of the nutrition program. Let that data and I am also beginning to foster some relationships with a number of different ALFs. No, I'm not the alien from the 80s show. We're talking about assisted living facilities, folks. I was just at an ALF in Fortuna, very cool continuing care retirement community. So we're looking to embed the student into the care environment and work specifically with the activities director so that they can get some clinical experience and then also do a needs assessment to see a potential research project that can help inform the care. Yeah. And I'll end here. Any of this sounds interesting, if I haven't completely bored you to tears, consider taking Psych 415, Psychology of Aging and Older Adulthood, taught by yours truly, every fall semester. So it'll be offered this fall. When we were rearranging the major, we realized, well, we've got a class, child development, adolescence, and young adulthood. What about older adulthood? Developmental psychologists love saying, well, we look at the entire lifespan, the womb to the tomb. So we realized that there was a gap there in our course. I know I'm quoting Dr. Bill.
Hey, Chris, can I plug one more thing?
Yes.
Okay, so there's also going to be a gerontology certificate maybe next year, and it's totally interdisciplinary. So it's being housed in social work, but like pretty much, kinesiology is taking the bio. We have a psychological aspects of aging. They have a sociological one. They have religious studies working on death and dying. So you can take these courses in the near future as well.
Well, thanks for sharing that. Based on my earlier discussions there, I thought it was going to be a certificate for folks who are working in the community with older adults, but this sounds like it'll be available to students pretty quickly. That's great.
Yeah, that's not.
Well, if you're going to be around in the fall, consider taking Psych 415, where we will take a lifespan perspective and apply the biopsychosocial model to age-related changes. And I will also use that as an excuse to show lots of pictures of my parents. For you to do the same. If you to take them. And last, and I've got a couple copies here, if you folks want to flip through them and then take some pictures on your phone. This is from the Area 1 Agency on Aging. We also have copies in the Psych Department office that you can grab and take with you, but these I need to get. These are my copies. Run off of those. In it, you will see a variety, an exhaustive list of all the aging resources in Humboldt County, and also some volunteer opportunities if you folks are interested in maybe, in addition to learning more in an academic setting about aging, how you can get involved in providing care in some way. You can go to a1aa.org and also look for local volunteer opportunities as well. Okay. That was the end of my time, so I will say thank you.
And then really fast, we do have a section for questions if people are available. And then if you have stuff in the chat, please put them there. And before everybody leaves, because some people do have to get to class, we have some quick announcements for SOAR. We will be electing new officers for the for basically next term, and we are electing every position that we have available except for president. So if you're interested, there will be a form that will be going out hopefully Monday. So you can self-nominate yourself, and it will have questions that you answer and which positions do you want. And then we will vote at the end of April, and we will notify everybody. That's my main thing. There will be one more psych talk and potentially pro dev. We'll see for the rest of the semester. So keep an eye out. I know there's a lot of events in April. We got this. All right. Thank you. Are there any questions?
Yes.
The software for any repair reports for happiness, were there any like significant differences you could do, like if they always align and like what versus what was observed of them?
They generally align pretty well, they correlate pretty well, but there was some notable differences. Generally, that the observer will tend to rate them as just happy across the board, whereas the older adult might rate themselves in a more nuanced way, right? Because, well, they have access to those feeling states that we might label as happy, whereas the observer just has to gauge it based on how much they're smiling and all that. Well, some people, when they're happy, they're stone-faced. Maybe some folks are on RBF, right? So it might be an piece of clam, but you know, RBF. So hard to gauge sometimes, right? Based on overt behavior. So yeah, there were some differences, but overall they correlated pretty well. Questions? Yeah.
No, I think there is. I think everybody had it. Actually, I do have a question. Was there ever any like analysis or questioning about like people observing not wanting to overestimate people's happiness?
Like the older adults?
Yes. Or like fears of like overestimating or underestimating, so therefore it made them kind of skew towards the middle. Is there any about that?
Oh, right. It's like, I'm not unhappy, or I'm just kind of like, okay, right.
Or like people observing like, well, I mean, they look like they could be happy, but they also that could just be whatever, you know, do you ever think about?
Right, yeah, that's why we got some inter-observer agreement. So we had two raters independently score happiness for the older adults, in addition to getting their rating. But then we compare the two independent observers, see how well do they map on. Perfect match, 2/3 of the time, but within one smiley face, it was like in the high 90s.
Oh, yeah.
So So yes, subtle differences of like a smirk. I tend to, better or worse, that's how I tend to smile, it's kind of with a smirk. So usually people think I love this thing. But I'm not, I'm just expressing my happiness.
I do have one more question. So you know the scale that's the smiley faces? So when I was like 5 years old, I broke my leg and they used that scale on me. So that a lot of, like they use it for young children as well. Have any adults ever expressed like, oh, I'm at that age? Like they have to go back to, you know what I mean?
No, nobody responded that way. A couple of older adults asked if like, we were part of some kind of audit. What are you trying to get, place in trouble here? One older adult, he would constantly rate himself as a 5 out of 6-point scale. So we're like, all right, is this rote responding? He's not even checking with himself before pointing. So there were a couple of times where I tested to see if it was just rote. So I rearranged the faces and then presented it to him. And he's like, oh, you changed it. But he still found the number 5 out of order and selected that stuff. So just pretty happy guy. You all been so lucky. Good question. Yes.
There are articles, I don't know if they're very scientifically based, on Facebook and things like that about the elderly, you know, the 70s, 80s, even into 90s can be, obviously, you know, if you're tremendously impaired by Alzheimer's or something, it would be the case, but that writers, a lot of musicians, they do some of their best work at that time. And so I'm hoping this is the case. I'm 73 and I'm doing a bucket list BA. So, you know, I just think, well, that sounds pretty good. And is there any basis of truth in this?
Yes, well, actually, you can help me out here, but I think there's an entire chapter on creativity in older adulthood.
Yeah.
And yes, so we look at the problematic negative stereotypes and what the data actually show. And yes, it turns out people can still be prolifically creative at advanced stages.
Yeah, I think maybe you sift through some of the other stuff that you don't belabor quite as much. Also, one other thing, my mother was 93 and then my mother-in-law, she was the holy terror, but
Lifespan or
yes, and it just exacerbated, you know, that's one thing, you know, the tendencies of a difficult personality can be magnified, I think, or something like that. But mainly I was thinking in all of this and in the care homes, time for both my mom and several of my friends, the activities and how they're planned. Like my mom would say, oh, great, bingo, you know, and she was happy, but not as social. And another, he was a coach at Humboldt for years in the 60s. And he just said, you know, I've waited my whole life not to have breakfast at this certain time. And, you know, I've heard that so much and I feel that I would be the same. So, wonder what you thought about that.
Well, certainly, you know, when it comes to group activities, large group activities, yeah, and tend to be more boilerplate, not individualized. So the activity coordinator, thanks for coming. Adios. It's the activity coordinator, you know, is running those and planning those larger scale sorts of activities, bingo, arts and crafts. And some folks aren't into that. Well, then it probably warrants a follow-up, a more individualized level of care around activities. You know, what were their previous hobbies, preferences? Yeah, some people can get quite happy in activities, but it's a solitary activity. They don't want to be around other people. Especially if they've been that way most of their life. Why would they change that preference in their adulthood? So that's why it's important as part of an intake when you get a new resident to really get like some aspect or understanding of their life history, or their jobs, their hobbies, their preferences, their daily routines. So we can try to map that on as best we can, accommodate as best we can in the facility.
That sounds really good. My mom, her imagination, it was as though time was linear for her. And I don't know whether she had dementia at all or not, but she had a very rich imagination and life. And, you know, I used to just take notes and I've written a lot about her. It was amazing. And then she hated the last facility. And, but she imagined that it was a whole hotel that was just lovely, and she reinvented everything that was driving her nuts. So it was fascinating.
Interesting, okay. Yeah, I mean, it's important to acknowledge, yeah, they're stating like, I don't like it, you know, there might be something that even when folks can't necessarily articulate that, they have like a series of coercive or problematic relations with staff. Again, I don't want to throw all the blame on staff. They are overworked and underpaid.
And it's difficult.
And not all necessarily all that will effectively trade. Yeah, yeah. So, and they also are focused again, what's the bottom line? Being in compliance with the basic necessities of their medical care. They don't consider a lot of folks in these homes. There's a lot of psychological and behavioral components too in around providing medical care. So again, like training certified nursing systems are not very important, but to go back more to your comment, even folks who can't verbalize that they're unhappy or that they don't like somebody, there's emotional valence there. And even if they have memory loss, they can't remember that a staff member chewed them out. But the next day they see that staff member, that emotional conditioned response still occurs. I don't know why I don't like you. I don't want to trust you, but I'm not going to trust you. I don't like you. So they can't verbalize the negative experience, right? So that's why it's important to really follow up with those kind of issues. But if there's a concern about like delusional statements, stations, I would first do a medical rule out, look at their medication list. There's lots of psychotropic, all psychotropic meds are prescribed off-label to older adults. They're trying to manage their behaviors around dementia. And there are a lot of probably side effects, including hallucinations. And so the problem then doesn't become, how do we add on another drug to treat this side effect? How do we provide some effective behavioral supports and wean them off those drugs entirely? Because psychotropic drugs increases the risk of death. Well, they killed me in my mic.
Oh, I don't know.
Maybe I pressed that. Anyway, whatever is that Zoom meeting, I can talk about. Think maybe I addressed your comment.
Oh, yeah, wonderfully. Thank you.
Okay.
Are you getting into the inside? Yeah. Well, I'm hoping I'm English, but it was.
Thanks for sticking around. So see.
Thank you.
That was lovely, thank you. Oh. You can stop.
Yes.
Oh, what's on the English? Oh,